24-year-old Josh has been rushed to the ICU following a dramatic deterioration on one of the medical wards.
Just in the intensive care now, okay? Just going to swap you onto a different bed.
He's known to have mental health problems, but it's not clear why he's become so physically unwell.
Josh, hello. You're in the intensive care unit. We're just getting everything sorted. In a minute, we're going to pop you off to sleep. Just going to have a little injection in your hand, okay? Well done. All right, sweetheart. Well done. You all right, Josh? Your mum's here and your brother. Sorry. No, don't be sorry. Honestly, we'll move you if we need you moved, okay?
He's struggling to breathe, and he may also have a problem with his heart, so the team need to urgently support his organs.
Are you all right? We'll get you back out to the relatives room and we'll let you know how it goes, okay? Oh, I'm sorry, sweetheart. I know it's a slightly different mask and it's a little bit tighter on your face. Sorry. Okay, I'm happy. Great too. Okay, lovely. Breathe you out, thank you. 22 at the lips. Cuff can go up. Let's start with 60% oxygen. I'd probably go for people 10. Right, so that's secure. That's done. He's paralysed.
With his breathing under control, Josh is stable but remains in a critical condition.
Hi, my name is Manny Barbosa. I am an ICU nurse educator and I have been an ICU nurse for 30 years. The video that you just watched prior to this recording is a good example on what to do next when you need to intubate your patient. Usually we are intubating patient in ICU, but if we have to intubate the patient outside the ICU setting, sometimes on the med-surg floor, is during code blue. Okay, so if you are a new nurse and you're looking for information on what to do, you came to the right video. So my goal is for you to understand what your role, what you need to do next in the process of intubating patient in ICU. So I always tell the nurse you should know what to look for and that there is always this sense of urgency. So sense of urgency means that how soon can you act or escalate things that could help your patient not to get more complication or deteriorate. First, you should know the respiratory distress, symptoms of respiratory distress. If your patient is having really hard time to breathe, you should know that. If your O2 sat is dropping and your oxygen saturation is based on like your oxygen is you're going up with the oxygen and then respiratory rate is going down or going up, and you know that the patient eventually will gonna get tired, either you do an ABG and get the result and call the doctor, or you call the doctor and ask for ABG. So again, when calling the doctor, we always emphasize SBAR. What's your situation? What's the background of the patient? Your assessment, and what will be your recommendation. So normally what we're looking for is your ABG. If you have a PaCO2 of more than 50 millimeters per mercury and your pH is less than 7.30 and your PaCO2 is 60 millimeters per mercury, definitely your patient cannot guard the airway, because eventually he's going to get more obtunded. Then you will intubate this patient. So sometimes the doctor might say, why don't we use BiPAP, non-invasive? Just FYI, you can do that. Call the RT and the RT will bring the machine, but making sure you do not restrain your patient on BiPAP. Why? Just in case they will vomit, then they can always take out the mask and not get aspirated or aspiration pneumonia. So this is your ET tube. So the ET tube is to be inserted by the MD or whoever is trained to do that on your facility. Usually at night, on night shift, hospitalists will do that, call them, or emergency room doctor will come up. If you have an anesthesiologist on call, they will also come to intubate your patient. So this is the endotracheal tube. Again, I told you the tip will sit on 2/3 of the carina, and sometimes if the doctor will intubate too deep, it goes to the right main bronchus because it's straighter. And if you're only listening to the breath sounds and you hear it on the right side, that means you went deeper to the right main bronchus, and that needs to either get an x-ray and confirm and then pull it up. It needs to sit on the 2/3 of the carina, and then the RT will secure it using commercially tube holder, just to make sure that the patient won't pull it out. You restrain the patient. So we're going to discuss that on the part of the rapid sequence intubation and post-intubation care. So rapid sequence intubation is what we do in the ICU. Step 1 is you need to prepare all your equipment. So RT will get there, they'll bring in the intubation tray. The doctor will talk to the family member if they're at the bedside that we need to intubate the patient, and then take these family members to the waiting room. Bring in a gyroscope. Sometimes a doctor might use that. Determine the size of the ET tube based on the size of the patient. And if everybody's ready, step 2, you pre-oxygenate the patient. So normally respiratory therapists will be bagging the patient with 100% oxygen. And also, while they're bagging and pre-oxygenating the patient, you need to get your medication. So what medicine do you need to get? I ask the doctor sometimes, though they'll always tell me I need Versed, midazolam, fentanyl, etomidate. Sometimes they will ask for vecuronium or rocuronium. But just to let you know, you need to know your patient's potassium level, and then tell the doctor if it's hyperkalemia so that they know what appropriate medication they need to use. Then number 4 is, I would say, before you give your medication, you need to start a fresh new IV. The more the better, because once they get really sick, your veins are collapsing. You can't find them anymore. So while you still have a good vein, you can put 3 IVs if you want, because you're going to need it later. And then step 5, when you give your etomidate, the doctor will tell you when to give it. And once you give everything, they will position the patient. They normally fold a towel, put it under the neck to hyperextend the neck, and then they're going to intubate. And then 6, placement of the endotracheal tube inserted into the trachea, and placement is confirmed. So again, listen for bilateral breath sounds. And then step 7, post-intubation management. So after final adjustment of the ET tube, the level of insertion will be marked, or they were going to tell you 22 on the lip, 22 on the teeth, so depending on where. But normally they will use either the lip or the teeth. And you document that. And then you secure it. RT normally secures the ET tube. So here is a good picture. They're not really using a commercially tube holder here. They just temporarily use a tape, probably while waiting for the chest x-ray. Same way that they put an OG tube. So OG tube is what we want, not NG tube. Why? Because we don't know for how long this patient will be intubated. And if you're going to use an NG tube, you don't want to give this patient sinusitis. Okay, so OG tube. So you put an OG tube in, just like what you do when you put an NG. It goes to the mouth, down to the stomach. And then we're no longer checking for air. We'll just wait for the x-ray. So once the x-ray order put in, normally KUB, then they'll tell you if your OG is in or your ET tube is on the carina, 2/3 of the carina. So once everything is confirmed, then the RT will put the commercially tube holder like this, and it's going to look like this, your patient in the ICU. Okay, again, look, there's no NG tube in there to prevent sinusitis, and you will secure it by placing bilateral soft wrist restraint. Why? So that the patient won't be pulling your tubes. And also start your propofol or Prasidex depending on your hospital policy or doctor's order. Normally they want Diprivan or Prasidex. And when you do that, you need to start at whatever the doctor's ordered for you to start. So don't jump right away to 10 mics. So start recording accordingly. I mean, if the doctor's order is 0.5 per kg per microgram per kg, then by all means you do that. And then you always going up incrementally depending on your RAS. Okay, what is Richmond agitation and sedation scale? Again, this is if they're -1 drowsy, -2 light sedation, -3 moderate sedation. So sometimes a doctor wants you to stay within -2 to 3. But when you do this, make sure you follow the definition of what is -2. So -2 is briefly awakens to voice, meaning if I call their name or I say something, they will try to open their eyes. Okay? If you're calling their names and they're not answering or doing anything, but you start touching them for them to respond, that falls onto -4 or 5. Then that means you're giving too much sedation. So you go slow with your sedation. And I think that's all for now. That's pretty much what you need to know when you intubate your patient. I thank you for your time.